Okay, I'm going to convene us. Good afternoon, everybody. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. And on behalf of our school, welcome to today's event. Today is our first public health forum to take place in the context of the COVID-19 pandemic. We are pleased to have transformed this, what was planned initially as an in-person meeting, into a digital forum. Thank you to everybody who responded quickly to shifting the programming online. Thank you to our speakers who have been so flexible, and to Meredith Brown and Alicia Noel, whose efforts make this possible. Thank you too to the intellectual lead of today, Dr. Bob Horsberg, and to all of our school's experts on tuberculosis and infectious disease. And of course, a special thank you to the heroes of the hour, any health workers who may be watching. As COVID-19 unfolds, your efforts help make the difference between sickness and health for all of us. Thank you for what you do every day. Now, today, the plan is to do something which few of us who work in public health have done in recent weeks. We will pause our conversation about the coronavirus. The current pandemic is serious and worth the attention it's received. But it's important to remember that public health goes on. There are other challenges to health, which did not stop when COVID-19 entered our consciousness. Tuberculosis is one of those challenges, and one that, to my mind, unfortunately never gets as much attention as it should. Globally, tuberculosis is among the top 10 causes of death and the leading cause from a single infectious agent. In 2018 alone, an estimated 10 million people fell ill with tuberculosis, and it kills a total of 1.5 million people a year. It's worth noting that the novel coronavirus has not even begun to approach anywhere near this morbidity level, nor is it likely to. TB is also a disease we can end. Today, we are going to talk about how we can do so. Our discussion is going to be led by Dr. Susan Cu-Uvin. Dr. Cu-Uvin is Professor of Obstetrics and Gynecology, Director of Global Health Initiative, Professor of Health Services, Policy and Practice, and Professor of Medicine at Brown University. She is also Director of the Providence Boston Center for AIDS Research. This is a partnership between us at Boston University and Brown University. We are delighted to welcome Dr. Sue Cu-Uvin. Over to you.
As you said, these are very trying times and difficult times, but I am very happy that we're able to continue doing many other activities that are not only related to the coronavirus. The topic for today is TB, the hidden epidemic, and our first speaker is Dr. Kogi Naidu. She's the head of the treatment research program at the Center for AIDS Program at Research in South Africa, or known as CAPRISA, and an honorary associate professor in the College of Health Sciences, University of KwaZulu-Natal in South Africa. She serves on the WHO HIV Treatment Guidelines Committee and the WHO TB HIV Technical Working Group, and as a board member of the South African HIV Clinicians Survey. Today, we welcome Dr. Naidu to give us a talk on TB, the hidden epidemic. Dr. Naidu?
Good afternoon, colleagues, and thank you very much for giving me the opportunity and the platform to share some of our insights on tuberculosis. I have a few slides to share with you, and I'll be good to go shortly. My topic for this afternoon is tuberculosis, the hidden epidemic. And when I reflected on this topic, I was reminded of a cartoon character, Where is Wally, a British cartoon character that was very popular in the 1990s, where Wally would go to some common music locations, and people would spend hours poring over the cartoons trying to locate Wally. And interestingly, Wally was always there in plain sight, just like tuberculosis. The TB is there, but just hidden in plain sight. So the overview of my presentation is to discuss why is TB a hidden epidemic, to look at who is most affected, how do social determinants drive TB, where are TB cases and deaths, what are current and past TB investments, looking at contrasting epidemics, and a few summary remarks and conclusion. So why then is TB a hidden epidemic? We know that it affects the most marginalized in society and the vulnerable, the poor, the sick, the HIV infected, those that live in overcrowded situations and are undernourished, often intravenous drug abusers, and the homeless. There's stigma surrounding TB, so it's hidden amongst communities, it is hidden in society, and certainly people take, they become really ill before they present to health facilities to seek care. TB is historically been associated with a lack of advocacy efforts and the lack of a voice to raise the platform and to demand services and recognition. And with the limited resources, there's been corresponding lack of funding for advocacy, funding for efforts, research, development, new drugs, diagnostics, action within programs to find cases to better diagnose TB and initiate people onto therapy, and then accountability for poor performance of programs. So it's no wonder that TB has remained a hidden epidemic. We have various groups that are most affected by TB. Prisoners and those living in congregate settings. We discuss people living with HIV. Those that are malnourished have increased likelihood of breakdown of latent TB infection and progression to TB disease. The elderly, those that have poor access to food, and at the extremes of age. And of course, with high population density and overcrowding, there's enhanced transmission of TB. And that enhanced transmission in the right circumstance would lead to greater progression to TB disease. We know that proximate risk factors have contributed to TB disease in society. There's about 6 billion individuals globally that have latent TB infection. And with the right biologic and social set of circumstances, you have progression from latent TB infection to active disease, and thereafter long-term complications like chronic lung disease and recurring TB infection. But there's multiple factors that interplay in driving TB. These include the impaired host defense, which are compounded by a set of social, biological factors that all accelerate the progression to TB disease. In addition, there's upstream determinants, including inappropriate and delayed health-seeking behavior, poor access to care, poor access to diagnostics, unhealthy behavior, as we're now seeing a resurgence of TB associated with diabetes and other non-communicable diseases. And all of this in the context of poor health systems, poor policies, and the impact of migration and displaced populations. Through the ages, sanatoria was developed as recognizing that TB occurred amongst the poor and marginalized, and initially was set up to manage people with TB in the 19th and 20th centuries, to offer a haven where TB patients could be cared for, given proper nutrition and one-on-one care with a TB nurse. So it was intended to create isolation with the first advent and recognition that TB was caused by germs, to create a situation where patients could be isolated away from communities and receive proper care. However, this, as had unfortunate consequences, creating social stigma, leading to patients being treated as outcasts. So despite the absence of sanatorium now in modern society, patients with TB still remain outcast and stigmatized. We've seen the rise and fall of TB in the last century. Early on, we saw high rates of tuberculosis pre-1900s due to rapid urbanization and overcrowded settings where there was enhanced transmission of tuberculosis. At the turn of the century, when TB was identified to be caused by a germ and greater recognition was given to tuberculosis, we saw gradual decrease with better housing conditions, reduction in poverty, and overall improvement in the social and living conditions of patients. We saw transient increases in TB rates during the wars, the First and the Second World War. However, the steady decline of tuberculosis continued. This was accelerated with the discovery of drugs that could potentially treat tuberculosis. And as more drugs became available, we were doing better at diagnosing and then treating TB. Concomitantly, the Industrial Revolution, availability of jobs, the improved social and living conditions all contributed concurrently with the reduction of TB that we saw that continued through the ages. And we all became complacent, believing that TB indeed was conquered. Unfortunately, that complacency resulted in a lack of investment in tuberculosis, the lack of new drugs and better diagnostics, so that when TB resurgence started occurring with loss of control of TB programs in many settings, higher levels of migration, emergence of HIV and drug-resistant TB, the tools that we had to fight tuberculosis were decades old, and there had to be a new impetus in fighting TB as the world started seeing far more rates of TB than we'd expected to see. So where are the new TB case notifications occurring? As you can see, this is data from the 2019 Global TB Report, where much of sub-Saharan Africa is seeing TB incidence rates of more than 500 per 100,000 population. Most patients that are affected in all forms of TB are men, with women and children occupying about 3.2 to 1.1 million cases per annum. So these are the cases that were notified in 2019 alone. HIV-associated TB accounts for just under 10% of all TB notifications. Of note, the deaths amongst HIV-associated TB accounts for about a third of all deaths from TB, largely occurring again in much of sub-Saharan Africa. When we look at the burden of tuberculosis, we find that 66% of the burden occurs in just 8 countries. Many of these countries also are ranked amongst the top burden countries for HIV. South Africa, at the bottom of the list, is ranked #1 for the burden of HIV globally, and also holds the 3rd largest population of patients with tuberculosis. Here, much of the TB that we see is HIV-associated TB. Other countries from Africa, like Nigeria, also ranked 2nd with the global population of HIV and 4th with tuberculosis. So the twin epidemics of HIV and TB the HIV has been driving the TB that we've been seeing over the last 2 decades. This Airbus, with all passengers waiting outside, paints a very powerful picture that reminds us that every single day, approximately 3,000 patients die from tuberculosis. If there were 4 Boeing A380 air crashes a day, the whole world will sit up and take notice. But unfortunately, the TB deaths are occurring quietly. They're hidden and swept under the carpet, and it is not something that we've been taking very seriously. When we look at TB mortality and TB incidence globally, again, looking at sub-Saharan Africa, Mozambique, showing us that there are, with a TB incidence of just over 500 per 100,000 and TB mortality of 72 per 100,000, Nigeria 64 per 100,000 mortality from TB, and then South Africa. So we have settings where TB mortality rates are unprecedented, yet despite this, there hasn't been much attention to, we're recognizing that this is a problem, but we don't yet have solutions, despite TB being preventable, treatable, and curable. In 1882, Robert Koch first recognized that tuberculosis was caused by a germ. And it took approximately 54 years before we developed better TB diagnostics. The emergence of the emergence of XDR TB in 2005 catapulted a series of diagnostic developments to help us to better recognize TB faster with simpler genotypic methods. And we've seen far better strides and bigger strides in TB in the last 15 years than we'd seen in the 100 years before that. Now, for the last 10 years, it's been amazing. We have rapid point-of-care diagnostics that have been rolled out to many, many different settings that are both resource limited as well as deep rural. And despite that, TB mortality still remains #1, and there are many millions of TB cases that go by undiagnosed each day. In addition, the investments in TB drug discovery have been started off late after recognition of TB, with the first randomized trial of streptomycin coming through in about 1946. Through the years, drugs have come through from first discovery through to actual a pill in a patient's mouth takes several years of clinical trial and development. It took approximately 46 years for there to be for bedaquiline to be developed and shown to be effective in the treatment of drug-resistant TB. So despite it being discovered in 2005, in 2016, we had bedaquiline, which has transformed the drug-resistant TB landscape. The advent of fixed drug combination for drug-susceptible TB in the 1980s, the drug discovery in the 80s, and then fixed drug combination being available about a decade later, transformed drug-susceptible TB. But it's been more than 40 years, and we haven't actually improved on shorter, more effective regimen for drug-susceptible TB. We seem to be doing far better with diagnosing and treating drug-resistant TB than we have for drug-sensitive tuberculosis. All of these improvements in diagnosis and treatment of tuberculosis has not really helped the patient. I walk you through a patient pathway that this is somebody that I met fairly recently, who presented to the healthcare facility in September 2019. He first noticed his symptoms about 3 months before that, and due to delays in accessing funding to attend a health service and failure to recognize that the symptoms as tuberculosis, there was about a 3-month delay before the patient presented. At the health service, the healthcare provider gave the patient a trial of antibiotic therapy and sent him on his way home. Patient presented for multiple visits thereafter, sent back home without a TB test being offered. 2 months down the line, patient is sicker, has lost weight, presents for the 4th time to the health service and has a TB test offered and sent to the laboratory. The patient is asked to return in a month's time to receive his TB test result, and this in the era of gene expert testing being available. The patient returned and the TB result was the sputum was insufficient, a repeat sample was done, the test result could not be found, and then several months later, TB treatment is actually started. It's only a few months into visiting the health service that the healthcare worker recognized that an HIV test needed to be performed for this patient because HIV-TB co-infection rates in this setting is approximately 70%. Antiretroviral therapy was not started immediately despite a diagnosis of TB, and the patient is still in care and we hope will achieve a TB cure in a few months' time. This patient's journey illustrates the failure of patients to recognize that they're at risk for TB, the failure of health education to reach patients despite TB being such a huge problem in our part of the world. The access to the diagnostic and the availability of the diagnostic didn't really impact this patient, with him needing to come to health facilities over multiple trips before he could access the test and then initiate treatment. So weak health systems and the failure to recognize, offer a diagnostic test and initiate TB therapy drives TB, again, contributing to it being a hidden epidemic. So I want to contrast tuberculosis, and I know Sandro mentioned that we're going to have a break from the COVID-19 epidemic this afternoon, but it's difficult to not reflect on COVID-19 given how visible it is and uppermost in all our minds. TB results in over 3,000 deaths per day worldwide. Yet COVID-19 results in approximately 100, the number is far higher now, but this was taken on the 16th of March, just over a week ago, at the time where COVID-19 was contributing to 144 deaths each day. So, you know, despite TB contributing to this number of deaths over many, many years, we still don't have that knee-jerk gut response to TB as we've had with the COVID-19 epidemic. The estimates of infectiousness of COVID-19, where the yellow circle indicates a person who is infected, transmitting to at least 2.5 individuals, transmitting COVID-19 to 2.5 individuals, whereas with TB, what is known that TB transmission from an infectious person occurs to approximately 10 individuals. The case fatality rate with TB is around 11%, and what we know up until about a week ago was that the fatality rate from COVID-19 is roughly between 0.7 and 3.4%, similar to the Spanish flu of 1918. The donor funding for research for COVID-19 has been unprecedented. TB receives less than $1 billion of the share of funding, and this is over a 12-month period, whereas research and development investments for COVID-19 just over 3 months has received about $8.3 million. We know that epidemic control for TB is achievable. There's several interventions that have been tested and has shown that if taken to scale, is likely to help us achieve epidemic control for TB. So in summary, my remarks are that TB is not a hidden epidemic. It is there and it is in plain sight. The leading cause of death from an infectious disease worldwide. It affects the poorest and the most vulnerable in society. And the problem is that TB has been largely ignored. The complacency has come from the drop in TB notification rates that occurred before 1990, where the perception was created that TB can be beaten. There was reduced interest for TB research and development and investment, and the commensurate reduced funding. And the suboptimal response, the lack of investments has led to our suboptimal response for the HIV-associated TB that for the last 2 decades has really been decimating societies. There's been massive recent gains in new drugs and diagnostics. However, these have been insufficient to meet the needs, largely due to weak health systems and inability to implement. The global emergency response to the COVID-19 indicates that resources are available and needs to be mobilized for TB. Our former President Nelson Mandela in the 2004 AIDS meeting in Bangkok had these remarkable words to say that the world had made AIDS a top priority and that TB remained ignored. And he made a call to the world to recognize that we can't do much to fight AIDS unless we also fight TB as well. Back in 2004, those words held true, and they still hold true now, 16 years later. Thank you very much for your attention.
Thank you, Dr. Naidu, for that wonderful talk. We will proceed to our second speaker, and Dr. Kenneth Castro, who is a professor at the Rollins School of Public Health, is a physician scientist trained in epidemiology with specialty in internal medicine and subsequently in infectious diseases. He is currently a professor, global health epidemiology and infectious diseases at the Rollins School of Public Health and School of Medicine at Emory University. He is a senior TB scientific advisor to USAID and also the Bureau for Global Health. He was the director of the CDC's Division of Tuberculosis Elimination from 1993 to 2013. Dr. Castro is giving a talk today, How Can We End TB? Please welcome Dr. Castro.
Thank you very much, and good afternoon, everyone. I'm sincerely honored to join you on this commemoration of World TB Day, yet disappointed that we have been forced to change from an in-person to a remote venue. I very much appreciate Dr. Galea's opening remarks and Dr. Naidu's presentation. And what I will do is review with you the requirements for ending tuberculosis. As a way of overview, during my presentation, I will try to address these questions. First, what is the goal and progress towards the elimination of tuberculosis in the United States, and provide a bit of a background history about TB elimination in the United States. Is there a global strategy? And if so, what is it? And end by describing remaining challenges and unmet needs, both in the United States and globally. In 1989, the United States Department of Health and Human Services and the Advisory Committee for the Elimination of Tuberculosis published a strategic plan for the elimination of tuberculosis in the United States. This plan was formally endorsed by the American Medical Association, the American Public Health Association, the American Lung Association, and the American College of Preventive Medicine. Elimination was defined as an incidence of 1 or fewer persons with tuberculosis per million population per year, with emphasis on targeted interventions to reduce morbidity and mortality. Ironically, as that plan was being developed, our nation was experiencing an unprecedented resurgence of tuberculosis, which lasted from 1985 through 1992. Following more than 3 decades of a steady decline in TB morbidity, which had previously averaged about 5 to 6% annual decrease. An estimated excess of 52,100 persons should have never developed this disease had the previous trend continued. Several conditions were associated with this resurgence and have been documented in previous publications. The stage for this predicament was set by the dismantling of tuberculosis clinical services during the disappearance of categorical funds in the late 1970s and early 1980s. Other conditions include the HIV epidemic, immigration, transmission in congregate settings such as hospitals and prisons, and the widespread occurrence of multi-drug resistant tuberculosis. In response, at that time, the federal government partnered with others and developed and published a national action plan to combat multi-drug resistant tuberculosis, and received new funds from Congress to begin the implementation of several action steps depicted in these cartoons and outlined in that plan. These resources were quickly mobilized to improve the identification of persons with tuberculosis, to upgrade state laboratories for early diagnosis and recognition of drug resistance with routine and systematic drug susceptibility testing, updated treatment recommendations, paid for the broad-scale use of directly observed therapy as a tool to promote and improve treatment completion, and with emphasis on ongoing program evaluation, and funded research to identify new diagnostics and treatment regimens. This figure shown here is taken from the Institute of Medicine's May 2000 report, Ending Neglect. It documents the cessation of categorical TB grants between 1972 and 1982. It was not until 1989 that grants were reinstated to the level seen in 1969. You can also observe, as depicted by the arrow, the largest single increase of funds during fiscal year 1993. That same Institute of Medicine report provided several recommendations to get back on track towards tuberculosis elimination. These are the 6 elements of the ongoing strategy being applied in the United States. First, maintain control of tuberculosis. Second, accelerate the decline by targeted efforts. Third, invest in the development of new tools. 4, increase the United States' involvement in global efforts against tuberculosis. 5th, mobilize and sustain support for elimination. And 6th, track progress, identify and overcome bottlenecks. One of the biggest challenges we face in public health is documenting what did not happen as a result of interventions. We therefore developed mathematical estimates using as counterfactual 2 separate scenarios and a model that included program performance indices. The first scenario assumed a steady tuberculosis incidence since the peak of the resurgence, accounting for population growth. The second assumed a steady incidence in foreign-born persons and a 5.1% annual decrease in United States-born persons as observed. And the model incorporated tuberculosis program indices and outcomes between 1995 and 2004. All of these scenarios were compared against the observed decrease in TB incidence. During this time period, we estimate that between 145,000 and 314,000 TB cases were averted, with societal economic benefits ranging from $3.1 to $6.7 billion if you exclude deaths, and up to $6.7 to $14.5 billion when deaths are included in the estimate. This graph shows continued progress reflected by a relatively steady decline in tuberculosis incidence since 1992. Although you will appreciate a more recent slowing in the rate of decrease. In fact, over the last 5 years, the rate of decrease in tuberculosis has averaged about 2%, whereas in the previous 7 years, it was about 6% per year. The incidence nadir was in 2019 with 8,920 cases provisionally reported by CDC last Friday, but yet we have a 27-fold higher than number than necessary for elimination. In the United States, key affected populations include non-US born, who account for 70% of reported cases, with a case rate of nearly 15-fold higher than in the US born. Mexico, Philippines, Vietnam, China, and India are the top 5 countries of origin for more than half of the foreign-born persons. In addition, 88% of TB cases reported in the United States are racial or ethnic minorities. And you've heard from Dr. Naidoo how TB preys on the disadvantaged. Other key groups include HIV-infected, homeless, incarcerated, and substance users. Our main challenges to achieving elimination in the United States now include the waning political commitment as cases decrease and tuberculosis is no longer perceived as an important health problem by the public or policymakers, loss of proficiency and expertise as TB becomes a relatively rare disease, drugs and biologic shortages, ironically, driven by lack of market incentives, and the continued occurrence of sporadic outbreaks in increasingly difficult to reach subpopulations. We also must address the large burden of people with latent tuberculosis, estimated in the United States at 13 million people. All mathematical models have clearly demonstrated the crucial need to effectively identify and treat people with latent tuberculosis and at risk of disease progression to achieve the accelerated progress for disease elimination. I would also underscore the need to maintain control and treat people with TB disease simultaneously. Moving now to global commitments. In 2015, the United Nations Sustainable Development Goals clearly state the goal of ending tuberculosis among other targeted diseases, and as shown on this slide. That same year, the World Health Organization and partners developed a strategy to end TB consistent with those Sustainable Development Goals and adopted in 2015 by the World Health Assembly. It has clearly stated goals and phased targets. The strategy consists of 3 pillars buttressed by governmental stewardship and accountability with monitoring and evaluation, strong coalition of civil society and communities, protecting human rights, ethics, and equity, and adaptation of the strategy and targets at country level with strong global collaboration. I will next review the 3 pillars. The first pillar is integrated patient-centered care and prevention to ensure early diagnosis with universal drug susceptibility testing and systematic contact investigation. All patients are to receive optimal treatment regimens informed by drug susceptibility results and patient support to improve adherence and completion of therapy. Contacts to and others with latent tuberculosis and at risk of disease progression are to receive treatment, including the use of shortened defective regimens that have become available since the year 2011. HIV and tuberculosis programs are to implement collaborative activities and manage co-infection for optimal outcomes, especially in countries riddled with HIV, as you heard from Dr. Naidoo. Pillar number 2 consists of bold policies and supportive systems, aiming to achieve the crucial political will accompanied by resources for care and prevention, engagement of affected communities, civil society, public and private sectors. In other words, TB prevention control should be everybody's business. We also need social protection and poverty alleviation to minimize catastrophic costs, especially mindful of the social determinants associated with tuberculosis, and which you've already heard about from Dr. Naidoo. And universal health coverage with proper regulatory systems for access to quality assured diagnostics and drugs, as well as strengthened surveillance systems to track progress and outcomes. Pillar 3 calls for intensified research and innovation to develop new tools as well as optimal use of innovative methods for improved outcomes. More recently, in September of 2018, the United Nations General Assembly held an unprecedented high-level meeting dedicated to tuberculosis. Prime ministers and other heads of state signed a declaration with a crucial commitment to ending TB globally and provided specific targets which must now be tracked. Specifically, we're aiming to achieve by 2022, first, the successful treatment of 40 million people with tuberculosis, including 1.5 million children under 15 years of age. Second, successfully treat 1.5 million people with drug-resistant tuberculosis, including 115,000 children. And third, provide preventive therapy for 30 million people with latent tuberculosis, to include 4 million children, 20 million adult close contacts, and 6 million people with HIV. In addition, these commitments call for increased investment and other concrete actions. This busy slide shows the financial commitments for the implementation of national strategic plans for tuberculosis in 30 high-burden countries tracked by WHO. The top cluster shows 8 low-income countries. As depicted by the green color in the bar graphs, these are mostly dependent on grants from the Global Fund Against HIV, AIDS, Tuberculosis, and Malaria, and in blue, other donors, and in yellow, you see the immense budget gaps for implementing these national strategic plans. Please look next at the bottom cluster for 6 high middle income countries. Here you see that they mostly depend on domestic resources, or the fuchsia or lilac color, depending on how it's projecting, with less donor dependence and modest to no budget gaps in implementing those national strategic plans. We go next to the middle cluster, where we have 16 low middle income countries. Except for India, these countries also rely heavily on Global Fund and other donor funds and experience immense budget gaps depicted in yellow. In spite of remarkable progress made against tuberculosis, with an estimated 58 million lives saved and 38% reduction in deaths between the years of 2000 and 2018, funding gaps continue to plague us and impede accelerated progress. The bottom left set of graphs show that international donor funding has increased over time for all three diseases, yet tuberculosis remains woefully underfunded in contrast to the other two diseases, as depicted in the bottom blue graph. WHO has also estimated the funding gap in 2019 as being $3.3 billion, and the funding gap for research as being $1.2 billion. More recently, the Stop TB Partnership got together a group of experts to estimate the cost of achieving the United Nations high-level meeting targets. Between the years 2018 and 2022, $77.8 billion are needed, including $65 billion for treatment, prevention, and control, and another $12.8 billion for research and development and basic science research. Another more acute challenge that has emerged in recent years is competing priorities. This photo was shared with me by Dr. Hannah Kirking, who was deployed from CDC's Global Division of HIV and Tuberculosis to help respond to the Ebola outbreaks in Western Africa and later in Democratic Republic of Congo. And she showed me this photograph of a site that was previously used for tuberculosis. And we see how these ministries of health often have to balance limited resources between diseases and health programs. Last week, Forbes published online Dr. Madhu Pai's concerns in anticipation to disruption in services for tuberculosis as we implement a required global response to COVID-19. Ironically, the relevant expertise held by people in TB programs make them more likely to be repurposed or deployed, placing these program services at risk of being one of the biggest casualties. Madhu recommends a proactive stance to anticipate and mitigate the damage and provides 10 specific observations and recommendations. And I invite you to link on the web link that I've provided to read those recommendations that he has provided. These graph projections developed by WHO demonstrate that the 10% per year decrease in incidence of tuberculosis that is needed by 2025 has been only previously achieved within the wider context of broader social and economic development as seen in European and Western Hemisphere countries after World War II. This will require providing all people with optimal access to services of sufficient quality and without their use imposing a financial hardship. Progress in the countries with the highest burden today, such as China, India, Indonesia, Nigeria, and South Africa, will strongly influence whether the targets can be achieved or not. To lower cases to a rate of 10 per 100,000 population by 2035 and achieve a 95% reduction in TB deaths by 2035 will require a technological breakthrough by 2025 that will allow an unprecedented acceleration in the rate at which tuberculosis incidence falls in the last 10 years of the NTB strategy. This will only happen with substantial investment in research and development in the coming years and up to 2025, so that ideally new tools such as a post-exposure vaccine or a short, efficacious and treatment regimen for both disease and latent infection could substantially lower the risk of developing TB, especially among the approximately 1.5 to 1.9 billion people who are already latently infected in the globe. Please allow me to digress and channel Dr. Bill Foege. During my formative years at CDC, he admonished us to look for the faces in the numbers and the graphs. Louie Zepeda is a Filipino architect who at the age of 24 developed fever, weakness, and fell during New Year's Eve in 2006. She was initially diagnosed as having typhoid fever, given medications, and sent home. Even though she resided in a high TB burden country, no one suspected tuberculosis. After no initial improvement, her symptoms progressed, and she was evaluated weeks later with a spinal tap and diagnosed with tuberculous meningitis. No drug susceptibility testing was obtained at that time. She was given the recommended regimen for drug susceptible TB, and this was followed by worsening disease progression complicated by coma, stroke, partial paralysis, and loss of vision. At that time, she had to be transferred to a premier hospital in the Philippines, where she was diagnosed with multi-drug resistant tuberculosis. Her treatment had to be changed to a 24-month regimen with a combination of oral and injectable drugs. During all that time, she required both financial and psychosocial support from the Tropical Disease Foundation to deal with her debilitating disease and avoid incurring catastrophic costs. Louie eventually recovered, remains with loss of vision, but has become a much needed voice and advocate, now part of the TB survivors and champions of the Global Fund Advocate Network. She now helps us monitor progress against the commitments and promises made by heads of state. The world needs an army of advocates such as Louie to hold our collective feet to the fire until we eliminate this disease for once and for all. I want to close with some relatively good news. Last October, the Global Fund, the largest single donor of tuberculosis funds, received a pledge of $14 billion for the next 3 years. This unprecedented show of global solidarity, combined with the implementation of all elements contained in the Global TB strategy, which I have reviewed with you, provides us with renewed optimism as we relentlessly continue to pursue our mission. Today, we commemorate World TB Day. I personally look forward to the day when instead we gather to celebrate the elimination of this ancient foe. I want to thank you for your attention and would be pleased to try to answer questions. Thank you.
Thank you so much, Dr. Castro. I empathize very much with Louie's story, having been born and raised in the Philippines and living in a country that is endemic or epidemic for TB. It's been a big problem, and almost all of Southeast Asia and the rest of Africa, TB is a major problem. Thank you for giving that talk. We will now open this session to questions. There are two ways that you can raise your questions, either through a chat or you can raise your hand through the Zoom program.
So this is Ken Castro. I see a question raised in the chat that says, I may have missed this already. How is tuberculosis transmitted? So I apologize for skipping over the basics, but TB is an airborne disease that is transmitted from person to person, mostly in congregate settings and poorly ventilated environments. It usually requires multiple hours of exposure to tuberculosis. And that's why we have also seen outbreaks in hospital and prison settings. But the way that we've learned tuberculosis is transmitted is when someone with the disease in the airways coughs or sneezes, they aerosolize these very small airborne droplet nuclei, which remain suspended in air and can be inhaled by others in relatively close proximity. I hope that answers that question.
Any other questions? There is a question from Dallas Smith to all the panelists. It disappeared from my screen. Can you see? Can you see Dr. Castro or Dr.?
So let's see. Are there strategies or action to raise domestic investment in high burden countries? The answer is yes, and that's precisely what was behind the 2018 United Nations high-level meeting. I must give a shout out to Minister of Health Aram Mortality, who was the Minister of Health in South Africa and the chair of the Stop TB Partnership Executive Committee. He emphasized that we needed to stop talking only to ministers of health, and we really needed to engage the prime ministers and heads of state. So that has resulted in efforts underway. There's a group of parliamentarians who are also trying to help raise the investment in high burden countries. But that is an ongoing effort. And hopefully in the slide where I showed the domestic investment, you can see how woefully poor many countries are in making their own investments and rely heavily on outside investments. Let me stop here because I see several questions popping up.
Yeah, there's a question from Dr. Horsberg to the panelists. 30% of persons with TB are not ever diagnosed, and they continue to spread disease to others. Why is not more effort being directed to active case finding? So Dr. Naidu or Dr. Garcia, please. Castro, I'm sorry.
So I don't want to monopolize. I'll let Dr. Naidu take a first crack. Go ahead.
Thank you, Ken. South Africa has a huge program on finding missing TB cases. I think the starting point should be more effort to TB contact tracing. Over the last 2 decades, we seem to have lost a fundamental strategy in controlling TB, which is screening household contacts. Household contact screening has not had any investment. There isn't a structured program in most high burden settings, largely because patients live in hard to reach communities, in peri-urban, squatter settlements and so on. It's been really difficult to reach. And we don't have a cadre of healthcare workers going out to find patients. As you saw from the example that I illustrated, patients coming to facilities with features of TB are often missed. The index of suspicion to screen for TB, to offer a diagnostic test is not high. And very often, patients with known HIV status ascribe their symptoms to HIV rather than TB. I think we need to do far more to strengthen finding missing TB cases. And it has to be a collective effort from both the community, with political will and resources, as well as within health settings. I'm not sure if Mr. Castro wants to add.
I would echo what Kogi just said. And in fact, globally, there's an increased effort and funding from the Global Fund provided for active case finding. Having said that, I think the countries need to know their own epidemiologic drivers because I would hate to see a lot of screening of low risk populations with low yield. As Kogi has suggested, the first low-hanging fruit would be the contact of people with tuberculosis. Studies have, in many high-burden countries, have consistently demonstrated that at least 2 and as high as 18% of contacts have TB disease. Many more are going to be latently infected. If you transform that to cases per 100,000, you're talking about 2,000 per 100,000 in a universe or in a globe where the TB rate is about 132 to 134 per 100,000. So we're looking for needles in haystacks. We just need to be smart about where to look. And the other thing would be high risk populations. In sub-Saharan African countries, we need to look for TB consistently among people with HIV infection. I would also turn to diabetes clinics in other countries to look for tuberculosis among people with diabetes. All these risk groups. There are many countries where they have malnutrition program for children, and they're not looking for TB. That would be another good setting to do active case finding. I'm going to stop here because I see several other questions popping up.
Would you prefer to read the questions yourselves and answer them since you can see them the same way as I do, or do you want me to read the questions?
Well, it doesn't matter. So Kogi, do you want to take a crack at the next one? So one of the challenges that I'm seeing is that we have a question and answer list, and there's also a chat, so they're separate, and I only have the question and answer open, and I'm seeing numbers showing up in the chat. So for the time being, I would encourage all listeners in Zoom to try to type their questions in the Q&A rather than in the chat section, so that we do justice and not forget to answer them. Having said that, Kogi, do you want to take a crack? I see the next one after Bob Horsberg's is from Monica Nolkar.
Yes.
Okay, so I'm actually I think I've lost my way along the chat.
Okay.
So I'm currently looking at Jane Oppenlander's question about a background on the relationship between HIV and TB. Can I take a crack on that?
Please, you're the right person.
So if an individual is HIV uninfected, that is HIV negative, their risk for developing TB disease is 10% per lifetime. However, if they are HIV infected and not on antiretroviral therapy, the risk of progression from latent to active TB disease is 10% per annum. HIV results in the host immunity being lost to tuberculosis. So the TB bacillus is able to break through and cause disease. Not only does it cause recurrent TB disease, it also causes disease in sites outside the lung. So extrapulmonary TB is commoner amongst HIV-infected individuals. TB overall is commoner, as is recurring tuberculosis. Dr. Castro, please add if you wish.
No, I don't need to add. I'm a bit concerned that we're getting a lot of questions.
Yes.
So,
I think we should just go after the next question so that we can answer everybody. The next one is from Monica Nulkar. Do you recommend treatment for people with latent TB that are leading productive lives? If so, what is the treatment?
So if you want, I can get started on this one. The answer is yes, especially if the person has a risk of disease progression. We do not yet have, and that's one of the things that needs to be researched. What are the ideally surrogate markers of disease progression that could reliably predict who's going to develop TB. Having said that, anyone who's leading a productive life has latent tuberculosis and diabetes, or is under a TNF-alpha blocker, or has HIV, or is a recent contact of someone with TB disease. First, you need to rule out the presence of TB disease. And once you've done that, you can offer these persons treatment regimens that nowadays could consist of once weekly isoniazid and rifapentine given for 12 doses for 3 months. And those have been shown to be quite effective, or you could give daily isoniazid and rifapentine. You could give 4 months of daily rifampicin. In European countries, they've often used daily isoniazid and rifampicin also for 3 months. Given what I've learned about the efficacy of all these regimens, I, for one, would not want to take a longer regimen. One caveat, though, is in high-burden countries, there is a potential risk of reinfection. And I know that in South Africa, Gavin Churchyard and other colleagues are trying to investigate the long-term benefit of these short-term regimens. I'm going to pause here and ask Kogi if she wants to add to this.
Sure. So in high burden settings, it is recommended that individuals with latent TB take TB preventive therapy. It's standard of care for HIV-infected individuals, those in congregate settings, and healthcare workers currently to take 12 months of isoniazid preventive therapy. Our guidelines are likely to change in the next few months to a short course of rifapentine with isoniazid for TB preventive therapy. So certainly it depends on the setting. If it's a low burden setting, then one may consider not putting a person onto TB preventive therapy.
We can move to the next question. It's probably a short one. Any knowledge of TB burden in rural Alaska?
I would not have it at my fingertips, but I would invite you to go to the CDC webpage and look for the annual tuberculosis reports, and you will see the tuberculosis incidence in Alaska, as well as state-specific and U.S. territories are all reported in there. Parenthetically, many of the most remarkable studies done by George Comstock were in Bethel, Alaska, with the Inuit population, where he showed that if you combine active case finding and treatment for TB disease with a mass use of treatment for latent tuberculosis, I underscore combine both interventions, you can drastically reduce the incidence of tuberculosis in these type of populations. But I will acknowledge my ignorance about the numbers in Alaska, but certainly direct you to where they have it readily available.
For both our panelists, is BCG vaccine used just for supportive treatment of TB? And is it still used in Asian countries and not in the US?
So BCG vaccine is given to all neonates at birth to prevent latent TB infection. It has been shown to be more effective in preventing disseminated TB disease, including TB meningitis, in children. It has not worked very well in preventing latent TB infection, certainly in high burden settings. A paper that was published last year in the New England Journal of Medicine showed that BCG revaccination amongst adolescents demonstrated protection, about a 54% protection against sustained quantiferon conversion, which is a surrogate for establishing latent TB infection. So it is used in Africa, it is used in some Asian countries, But my understanding is that it is not used in the US, and perhaps Dr. Castro would like to add.
Oh, thank you, Kogi. What I'll add is that if you look at the global TB report, they do provide information about BCG vaccine use and coverage. Over 150 countries in the world document over 95% vaccine coverage, partly because this is given at birth. You don't have to wait until the mothers bring the children back. So coverage is excellent. In the countries where it is used. Many European countries have stopped using it. We don't use it and have never used it in the United States. The main benefit that we're trying to achieve is prevent disseminated disease and death in children, as you heard from Dr. Naidoo.
Next question is, oh, sorry, Dr. Naidoo, you have something
Yeah,
to...
so the next question is, would it be worth testing people with COVID symptoms for TB? And I would say in high burden settings, I would say definitely yes. I think it is likely that we will diagnose far more TB amongst those that are coughing and presenting to health facilities. So it is worthwhile. In low burden settings where the TB prevalence is not something that we are concerned about, then of course it may be better use of resources directed elsewhere rather than at TB screening.
Thank you. This is Ken. I'll quickly add that in my work with USAID, we were recently very rapidly providing guidance to countries that are receiving USAID resources for TB programs. And it's precisely what you just heard. Very often the signs and symptoms of COVID are going to be fever, cough, night sweats, and all of these are symptoms of TB. So it would be important to make sure that you also screen for the presence of tuberculosis in these settings. Parenthetically, when SARS occurred back in 2003 and 2005 in Taiwan, they did screening for healthcare workers looking for evidence of SARS, and they found a bunch of TB. And this has been reported. I can find the specific reference, but it really shows you how, these are opportunities. And by the way, I did see that in the question and answer. I think it was Jane Carter asked about some of the challenges that come with opportunities, with billions of dollars being pledged to fight COVID. How can TB piggyback onto the response? Is it primarily by advocating for general health system strengthening? Yes. Or are there ways to benefit from these investments? One of the things that I just saw announced within the last, must have been 48, 72 hours, things are so dynamic with COVID that you sort of lose track of what, when did things happen. Cepheid announced that they have a cartridge for the detection of SARS-CoV-2, which is a virus that causes COVID. And this uses the modules that ironically have been purchased by TB and HIV programs for use in detecting these diseases in these settings. So I would hope that some of the investments, if they were to use that platform, end up buying many more modules that could later, after COVID is over, and I hope it will be, then they could be repurposed for viral load testing, TB diagnosis, and so forth. So those would be opportunities there. And I do think, I mean, every time we see these scenarios, the underscoring, but the thing that needs to be underscored is that we have allowed public health programs to be weakened and unable to properly respond to these emerging threats. And I think that while you fund the programs to deal with the urgent realities, the scare that results in the new investment should really come with a general health system strengthening in mind. That's a personal opinion, strongly held by me.
I echo all of your comments, Ken, and I also want to underscore the opportunities that COVID brings in driving home to communities the importance of infection control, regular hand washing, covering the cough, and the basic tenets of TB prevention and TB control that have been there in our community work that has somehow gotten lost through the ages. So you mentioned the improvement with health system strengthening, better diagnostics, and they all become part of the package where we strengthen the COVID response, and TB will likely also benefit.
Thank you. We have other questions, so I would like to move so that from Dallas Smith, what are your thoughts on bedaquiline and methods to increase access to it? MSF has been doing great social media work on raising awareness. Do you see, oh, I got lost. What happened?
Do you see
do you
prices?
see the prices being lowered anytime soon?
So actually, if you want, I can get started. But South Africa has been a leader in introducing a widespread use of bedaquiline for people with drug-resistant tuberculosis, which is the indication for it at this moment in time. And I also applaud the work done by MSF. Janssen Pharmaceuticals had partnered with USAID to facilitate access to the drug in many countries. Now I understand that the drug is going to be procured through the Global Drug Facility housed in the Stop TB Partnership, which enables pooled procurement and lower prices of these drugs. In addition to that, it could very well be, I'm not certain about bedaquiline, but certainly for protomimid, they're going to be talking with other people who manufacture the drug in India, Mylan, and others who are already producing TB drugs.
So one of the key issues is that we would like to reserve the use of bedaquiline for drug-resistant TB, and at this point in time, restrict use because we don't have that many drugs that work in drug-resistant TB. Several clinical trials are underway for the use of bedaquiline in both drug-sensitive as well as drug-resistant TB. But there are concerns with the use of bedaquiline in drug-sensitive TB. We currently in South Africa are seeing resistance to bedaquiline, the rates of about amongst treatment-naive patients at around 5.3%. So it is a concern, it's a relatively new drug, and so we would want to control access.
The next one is, what are the primary social stigmatizations toward individuals with TB, and what can be done to alleviate such stigmas?
I think the first and the most obvious is social isolation. Patients with TB are treated differently. They're ostracized, and there isn't much done within communities to assist. Part of that has come with lack of knowledge and awareness that TB is treatable and curable, and that once people are on treatment, their risk to society is minimal. And I think it's about community education and advocacy that will help with the social stigmatization.
I would just quickly add that the TB community has awakened to the need to harness the energy and voices of the so-called TB survivors and champions, and that's also going to go a long way. Not unlike what we saw happen with HIV, once you see public figures come out and disclose that they're HIV infected, that is one way to help ameliorate stigma. It doesn't do anything about the isolation that you heard Kogi talk about, and those are other elements that we need to constantly address.
Next question is from Becca Hadid. Hi, I'm a community pediatrician in the US, and I see many children that travel to Mexico frequently. Do you recommend that they get BCG vaccine when they are in Mexico, given the continual potential exposure?
So that's a very good question. It's one of these stump the expert type of question. As everything, I would individualize the decision depending on the risk of the children to progress. Now, if you're able to monitor these children, the first order of business is identify if there's anyone in their household with TB disease, and if they have evidence of infection, then give them a regimen of preventive therapy. If they're not BCG vaccinated, I'm not sure that I would go running to vaccinated. I would need to look at what are the up-to-date policies being used in Mexico. I'd much rather, especially if they're traveling, they're residing in the United States where they get healthcare in the United States, but travel to Mexico frequently, I wouldn't rely on the vaccine as the primary source of prevention. But I'm certain that you can present to me a case scenario where I might change my mind if you tell me they're being re-exposed to grandmother in Mexico who has multi-drug resistant TB, and where she's not responding to treatment, I might change my tune.
I see some questions in the chat. Are there strategies or actions to raise domestic investment in high burden countries?
I think I addressed that question already. Was the second one I addressed, yes.
I think some are the same, so.
Yeah, I think the folks who are managing the Zoom conference have kindly moved many of these questions from the chat to the question and answer, or the other way around, to make sure that we had them all in one place.
Yes. There is one. The impact of smoking and air pollution exposure is not frequently mentioned as a confounder of immunity, despite increasing evidence that both these inhalational exposures adversely affect protective human host immunity. Considering the large populations exposed globally to indoor and outdoor air pollution, as well as cigarette smoke, I'm wondering if TB elimination goals can be achieved without respective regulatory efforts.
That's a good one. By all means, in fact, we failed to mention that underlying emphysema or chronic obstructive lung disease is a well-recognized risk factor for tuberculosis. And in fact, I would invite you to go to the Global TB Report, because there's a section in there where they show the population attributable risk factors for many of the comorbid conditions that have been associated with tuberculosis, whether it's malnutrition, COPD, diabetes, HIV, and I forget that there's at least 6 of them that are listed. Absolutely, regulatory efforts that would diminish pollution and cigarette smoke would be very much welcome and would enhance the ability to address TB properly. I don't think it would be solely dependent on that, but I certainly would very much welcome it as a health practitioner. And I think it would go a long way at reducing the risk of disease progression in the quarter of the world population that's already latently infected by all available estimates.
And it underscores that TB is primarily a social disease, and it requires interventions, environmental, that it requires social and economic interventions. And so your pollution and air quality control is one of the environmental measures that can certainly help the problem of tuberculosis.
And I think we have one last question from Alejandro Galeano Molina. There are a huge number of people in South America who were vaccinated during their childhood, and their test is always positive. What is your recommendation for these patients? Should they be treated? I think
So-
it's the
No, go
BCG,
ahead, Kogi.
PPD.
Yeah, if patients are living in a low TB burden setting, the risk of conversion is higher than the general population, but overall it is low. So in South Africa, we don't have a situation where patients, where we have the luxury of not treating those individuals. But I would imagine that elsewhere, if you have the resources to observe patients closely and monitor, not treating them is an option. I'm not sure what the domestic policy is in the US.
So in the United States, we see this as a very common question. So two things to think about. One is that the reactivity to the tuberculin skin test associated with BCG vaccination tends to wane over years. If you keep repeating the tuberculin skin test, you're likely to see anamnestic responses and repeat positives. I would personally recommend moving away from the tuberculin skin test and relying on interferon gamma release assays, which are FDA approved. You no longer have the cross-reactivity, and therefore you can better ascertain the true state of latent infection in the people from South America who were vaccinated with BCG during the childhood and who may now be living in the United States.
Thank you so much. I don't see any additional questions unless I'm missing them. So I would like to thank our panelists, both Dr. Naidu and Dr. Castro, for such wonderful talks and very complete answers to our audience. I want to thank our audience, even if it's virtual. And I want, of course, to thank the organizers, Dean Galea, Bob Horsberg, and everybody else who's been working on this symposium. Dr. Galea, Dean Galea, any last words?
Yeah, I want to thank you, Dr. Cu-Uvin, and Dr. Naidu and Castro. I thought that was fantastic, and actually, I'm really grateful to the audience for all your questions. You know, it is hard at this time to sometimes think about anything other than a global pandemic that is galvanizing and captivating all our attention. But to be reminded about a disease like tuberculosis that has been with us for so many years and that continues to remain a challenge despite the fact that we have treatment for it is remarkable. I realized in my opening remarks, I apologize, I forgot to mention the World TB Day, which is the reason why we initially set this up. I thought it was a really perfect event for World TB Day. So again, I'm grateful to the speakers, grateful to the moderator, and grateful to everybody who participated. It feels, I must admit, it embeds a deep sense of the mission of public health to be talking about TB today on World TB Day, and to make sure that we emerge from this moment of pandemic to really embrace this moment for public health and to say public health's role is to tackle issues like TB, and that's exactly what we shall do. Thank you everybody for doing so. I hope everybody has a great evening. Thank you.
Thank you.
Thank you.